I think that is also used as an nebulizer in patients with hyperkalemia. The side effect is used for benefit also. Because in our emergencies and all, when a patient comes, even before the moment we know that he is hyperkalemic, first thing is we start a nebulizer with this, because that is the easiest to obtain. The other things may take at least few minutes, because that is something like a lifestyle. And we'll come to Dr. Ashokan. Is there any difference in treating hypertension in a non-diabetic patient versus a diabetic patient? Only with regard to drugs. Non-diabetic and in diabetic, are there drugs which you want to use preferably or avoid preferably?
It's a little controversial.
I know.
The question is, and the question is when to treat also, which level, whether to treat at 140, 90 or 130, 85. Anyway, if there is a proteinuria or any endorgan damage or patient has associated cardiovascular disease, then you have to treat even at 130, 85 blood pressure. The drugs, coming to the drugs, and ARB or ACI inhibitor, the drug of choice in this situation. And these are the important things. Otherwise, 140, 90 is the blood pressure, the level at which we have to tackle.
Would you use diuretics?
Diuretics is all questionable. A patient has hypovolemia, then we use diuretics. And whether to use thiazide diuretics, that's a...
Will it aggravate the diabetes?
That is a controversial thing.
You see that your opinion?
But guidelines says that we use diuretics.
Yes.
And thiazide is not
No,
contraindication.
if there is
as per the guidelines.
cardiac failure and all, there is
Yeah,
no
but
question.
trials have shown that it's a higher incidence of diabetes when you use thiazide.
In hypertension, will you, if it is diabetic with hypertension, will you add thiazides?
Thiazide can produce some degree of glucose abnormality, but that depends, sir. Suppose you have already used two drugs, BP is not getting controlled, and then as a third drug you have to add a diuretic. In that context you have to use. But that diabetic control is not very, the statin, thiazide, that known to produce some degree of hypertension, but not a major issue.
Okay, since I'll just ask the next question to you. In your practice daily, what diabetic complications do you see which can be managed as an OP case? That is mainly for the general practitioners and others. In your OP, what are the I'm not talking of very severe diseases like peripheral arterial disease, which may need interventions and other things. What are the simple complications you see?
Peripheral neuropathy can be very easily picked up in every bedside, because if you use the simple phenomenon and symptomatology, you can very easily, you need not go for the neuroconduction studies or anything, you can make a bedside diagnosis. And of course, if you are suspecting one microvascular complication, it is imperative that other complications will be there. You can always direct that patient for an eye checkup. You can always look for a microalbuminuria, because these are all going hand in hand. And of course, many of the musculoskeletal complications can easily picked up and diagnosed in the bedside. These are common complications that in the OP itself one can diagnose.
Yeah, that reminds me that looking at the fundus retina, not your fundus, not that retina, is very easy method. But do we do fundus examination nowadays?
Nowadays, our postgraduates do not carry. Previously,
no, because I thought it was wrong. It was only with my postgraduates. So your postgraduates are equally bad.
No, we had a kit previously. Nowadays, sir, it is there in my bag. I will bring if required.
Oh.
So now they simply refer to ophthalmologist.
So that means if they don't carry a ophthalmoscope, they will naturally not have anything to test the smell, no tuning fork. Knee hammer, I think they will carry. Because I remember G.K. Warrior would throw us out of the window if we don't have this. And this is not a joke, it happened truly. I gave my ophthalmoscope to one of our postgraduate students to examine. He turned it like this, put the light on his face and started. I said, please give it back. I know how to do it. See, that is the status nowadays. But that is one of the best places you can just see the arteries directly in the body. That will tell you whether the kidney is involved, isn't it? microangiopathy. That is very important. So ophthalmoscopy, even though you don't have to get a consultation from an ophthalmologist for this, right? And since that, I am going to the next question with you only. It is only an extension of this question. Do you order investigations in patients who come with numbness and tingling? That is, you are clinically now suspected diabetic neuropathy. Do you order any investigations in that?
No, we have to look at the control status. Of course, we will ask for a HbA1c because if the diabetes status is not controlled, because that is very, very important. Other than that, I don't think there is sophisticated investigation from the peripheral neuropathy part is required, provided the duration of the diabetes and the pattern of the neuropathy is consistent diabetes. No more sophisticated investigations are required. But if you have a diabetic duration is not agreeing with the degree of neuropathy, and you have to rule out some other, then you, of course you have to order for it. Not to make a diagnosis of diabetic neuropathy, many investigations are required.
You have these nerve conduction studies, pedopodogram, and so many other things.
It's not actually required.
What do you think is a good drug for that? For
Peripheral
diabetic
neuropathy. No. Peripheral neuropathy, there is no actually a single drug. Many drugs, whenever you have multiple drugs, none is as effective.
If you don't prescribe anything, the patient will change the consultant.
So we have the pregabalin, gabapentin, amitriptyline, all of them are being used with varying methods.
Amitriptyline is, I don't think, useful because they go to sleep and they don't get up for a long time.
In severe neuropathy, you give any extent, they will not sleep. Okay. So Isha sir will be able to comment on that.
My personal feeling is a better control of diabetes will be better than all these vitamins and sedatives. If you develop a severe neuritis, recently I had a femoral neuritis. Severe pain, lancinating pain, you can't sleep, you can't touch anywhere here. My way of treatment was a perfect control of diabetes. I think with that, usually it disappears or become better within 3-4 weeks. Till that time we will have wait.
What about medical time?
You used to give, may be useful, but the real thing is you make a perfect control of diabetes, and that is better chance for a recovery.
This is gabapentin and all, you cannot give for
You can, in small doses there is no harm, you can continue first.
Incidentally, what is said about this control is very important. If the HbA1c should be properly checked. No point in checking what the patient says, fasting blood sugar and all. He will not take any food the previous day and then bring a normal fasting blood sugar, and he will go home and take laddus. See, these our patients are, many of them are. So we have to go by the HbA1c. Okay. But there has been some benefit which I have seen with this pregabalin drugs like that. The other thing is patients who are on metformin develop a B12 deficiency, isn't it so? So their patient is on metformin for a long time. I think we should give them beta methacobalamin.
combinations are available.
Now combinations are available, but I don't think combinations will be available. Then they take extra cost from the patient for that. It's better to give the drug when it is necessary. So that way it is important. Now I come switch to cardiology again. Now I am going to ask a tricky question again for you. You are a very senior person, you need such questions. What are the common problems relating to cardiology that a pregnant woman with a normal heart, normal inverted commas, complain of? How do we tackle that? That is, patient has no heart disease.
Always asking very tough questions, sir. So, especially pregnancy, this you are talking about hemodynamics changes. So you know that the common symptom is palpitation. If any patient, lady, palpitation, that means complaints of palpitation. That means there is a volume, increased volume overload. The palpitation will be more on lying down. It's not like palpitation of any other secondary to tachyarrhythmias, where a sudden onset and offset. But more on lying down, palpitation is common. Second thing is edema, because the volume overload is very high. Cardiac output is more than 50% of the non-pregnant status. and tachycardia is more late stage of the pregnancy, and all the LV dimensions and RV dimensions are more, and these are the physiological things. So one is the cardiac output is more, and systolic stroke volume is high, and third one is the last trimester, the heart rate is more. So these are the three important things. So consequently the symptoms most common is edema, they can have a typical chest pain, and third one is the breathlessness, and all the way to thoroughly investigate and rule out the organic cause.
Yeah, of course we have to investigate. I just said normal because I wanted to avoid all the...
But the common symptom what I come across is the palpitation, and second one is the chest pain and edemas. These are the symptoms.
And all these are more common in primates.
Primates.
Because they come to us many often. I get patients for echo. I'm sure you also. They come for echocardiography referred by somebody. The symptom, I just ask them what's the problem. They say either it's dyspnea or it is palpitation. And the heart rate is a little tachycardia will be there invariably. And dyspnea will be there. Invariably for the first time their primates are seeing that they have enlarged abdomen, and that is what is producing the dyspnea, especially lying down and all. So I tell them this is all normal. Do you give them anything? Drug?
Don't give any drugs.
Yeah, that is the most important.
So that's one thing.
And I tell
This
them,
one condition where it's not used.
absolutely. I tell them don't take any drugs, and I don't prescribe any drugs.